many tools and many approaches of ablation of non-PV triggers, caffeine, tools, and biological ablation, and it's not still PVI, the cornerstone of AFablation. Well, listen from Professor Haissaguerre about the thesis about the future of AFablation. Is it will be durable technique of managing Fabrillation, or it will subside later
Thank you, Gamal. I will discuss about the future of AFablation. You prefer? It's better.
It's better.
Yeah. And we have new things. We have a new generation of electrophysiologists coming in Bordeaux, and they start with a protocol, and you will see that maybe there is a new way to ablate AFablation. I will show you at the end, and we are very surprised by the result, which are better than in persistent AF, of course, what we had before. This is to indicate, yeah. Oh, okay. Yeah. You know the recommendation, the guidelines. You see that electrical isolation of the PV is a cornerstone, and you see in the very last guidelines there is a lot of options that are discussed, like posterior wall isolation, like non-PV triggered linear, and there is a lot of confusion about that. What is sure is in the future there will be some study. They will show that AFablation is better than drug. They will show in paroxysmal or in persistent. They will show that in heart failure, if you restore sinus rhythm, is better for the heart function. And we will show that probably also in asymptomatic patients, they might get better if you restore sinus rhythm, even if they believe they had no symptoms before. But what you have to see is in the very last guidelines, there is a lot of confusion what we have to do in persistent AF, while for paroxysmal, we know that we have to isolate the vein. What happens if we do only PVI only in persistent AF? You see here some studies with follow-up of 5 years, 2 years, 3 and 6 years. If you do only PVI, you have to expect that only 20 to 30% of patients will go well. Now PVI is relatively simple, but it's just for a small part of persistent AF. But what we know from the study below here is the best profile for persistent AF cured by PVI ablation is a short-lasting PVI, less than 3 months duration, without any dilatation. And when you look inside the vein, you have a rapid activity. In this patient, we have 150 milliseconds within the vein, while the left atrium is 200. So everything is going outside the vein, and if you isolate the vein and you stop, you will have very good result. So short-lasting, no dilatation and no low voltage, and you get the profile of patient who will benefit of PVI. This is a small subset, but it's not bad. Now, when we look to STAR-AF, and we had a discussion yesterday about that, I would like to emphasize that we have done in the past. You may have the best mapping system to do CAFE, to do lines. You know exactly the mapping where on the rotor, but you can destroy the quality of mapping if the ablation is not well done. And we consider that quality of ablation is mapping is half of the job, ablation is the second half. And you can have a good mapping and fail because the quality of ablation, the contact, the duration, the power is not sufficient. And you will see at the end what we can get in terms of persistent AF when we have a high quality of ablation. This is just the method we use since 10 or 12 years, where we apply the PV plus the driver. We look inside the left atrium or in the right atrium, where are the rotational activity, the rotor. And when we apply the PV and the rotor, we have a lot of patients who terminate in sinuses. And how can we do that? In AFib, we can use different systems, complex, expensive, just to see where you get this rotational activity. But some people said, I will just work in sinus reason, I will do MRI, and where you have some fibrosis, it's like the stone in the river. If you have some fibrosis, it's where the tornado, the re-entry will fix. And some people said use voltage in sinus reason. If you have low voltage in sinus reason, that means you have some fibrosis, and like the stone is where you fix that. So you have different methods, but both try to find where are the rotational activity, the re-entry that we can control. The great majority of this re-entry lasts a few seconds, last a few rotations. When we have used, I'm sorry we cannot see well here, but you can guess here, when you see the electrograms, this is during surgical mapping or with a catheter, it seems that the rotation of one re-entry is always changing. You have one, second, third one, like if the electrogram changes, but it's really spatially unstable. And when we look how long they last only 2 or 3 rotations. Now it seems that in this chamber, you have 1 to 3, 1 to 3, 1 to 3, relatively short lasting. Now if you admit you have some re-entry, and you try to pick up the electrograms. If you have something turning from 1 o'clock to 12 o'clock, you will see electrogram moving from 1 to 12, changing like that. If you map this patient with a complex catheter, you see all electrograms activate at the same times. You see that? It cannot be a re-entry. If it's a re-entry, you will have a complex activity. In that case, that means there is just a wave passing here, but not a re-entry. So when you map your left atrium and you see some lesion with organized or synchronized activity, they cannot be re-entry. This is 100% sure. Now, when you see this complex activity desynchronized, it can be a re-entry, but it can also be just a U activation or a double collision or a figure of 8. You are not so sure. This is not re-entry, this is maybe a re-entry. And this is what is happening since 10 years. We ablate this complex activity and we have a result, but we have no specificity on that. Well, this is the case. If you map this patient, he had some activity. Look here near the left vein, it seems to be organized. If you look here, you see we have some activity again which looks to be on time. Here and here. And when you look on the other part, here for example in red, you see we have some potential here and other potential here. It may be a re-entry. That is how we distinguish hot and cold region. Now, when you don't have a lasso catheter, when you don't have a pentaray, these are the best signal to search using a conventional quadripolar catheter. When you get continuous activity, if you ablate, you will have a positive predictive value of 50%. When you ablate the lesion with complex activity, in 1 or 2 cases, this ablation will change the AFib. When you see distal and proximal activated sequentially, it may be a reentry, and again, local change will prolong cycle length in 62%. And finally, look at the electrograms at the bottom. You see we have activity of 100 milliseconds. It's like a mismatch in the VT, and in some centers they just ablate this long fractionate potential. Like if you are cutting a bridge, you have some bridge, and if you interrupt the bridge, you interrupt the reentry. This is the main location. When we look the region of left PV, left appendage, 98% of it's okay. Thank you. 98% of the region are reentry. In the right PV, we have 95%. In the anterior roof, 50. But for one single patient, the location of this reentry is different. You will have different reentry. This is what you observe. You have 12 different patients. You see this man adjusts something in the right PV. This man has activity everywhere. This man in the etc. Donc you had different scenario and a different type of ablation. Now, something which is probably the most important in practice. If you do ablation in a patient with, say, he's in sinus rhythm because you cardioverted, or it just lasts a few weeks, or you have 1 or 2 months, when you have short duration of AF, you have less driver than in you wait, say 1 year. In this patient, we have 3 months, 6 months, 9 months, 12 months more, and you see the number of drivers. If you see the patient in consultation, he's in AFib since 3 months, and you give an appointment 9 months later, because you are very busy, you do a very bad job. For the patient, you will have driver everywhere, and for you, you have to ablate everywhere. So it's better to calibrate and see the patient even in sinuses. This is the main message. As early as possible, or you do DC shock to avoid this contamination of the driver, the dissemination of the driver. Now something else. Look at the tracing below. This is V1, V2. If you look at your F wave in V2 here, you see here, you have a very short F interval, 120. 120 is 500 beats per minute. 120 milliseconds. In 1 second you have 8. It's 480 beats per minute. In that case, you will not stop it. There is so much remodeling, the action potential is so short that you cannot do ablation. In that case, it's good to give anti-arrhythmic drug, to give amiodarone, to prolong cycle length, and then you can do ablation. Minimize remodeling, ablate as short as possible persistent AF, and use of drug when you get short AF cycle length, and short AF cycle length, you can see that on the 12 lead ECG. How can we ablate the reentry? So we ablate the long fractionated electrographs. All these potential lasting very long are like small bridges. Contact force more than 10, and we commonly use 40 watt for 10 seconds. High power, short duration is better than low power, long duration, even for the risk of esophageal damage. And this has changed the life. If you do 25 watt, 1 minute is one application. But if you do 40 watt, 10 seconds, you do the job in 6 times less. This is really a big change in terms of ablation. Alright, look, this is a complex activity here. You see here. And after 10 seconds, you see particularly in the proximal, it becomes very slow. You have really hit a critical part of the circuit, and then 20 seconds after, distal proximal are the same. You organize a full vision just by one application. And this is what is the endpoint, the perfect endpoint. You see a complex activity here. They are desynchronous activity. It is in the anterior relay. You ablate and you see we organize it. This is a perfect result. What was a region of many tourbillons is now a region that you domesticate. And in the bottom, maybe you have ablate too much. We have a lot of scars, but it's okay. But this seems to be very elegant. This seems to be very efficient. I show you one example here, where you use a non-invasive, but you can do it with a catheter. You can target where are the main region, and in that case, we ablate the different region, and we have still something left here, and we terminate the F, and you see here it's relatively limited number of applications. It was 45 minutes, and then you restore sinus rhythm. So this looks wonderful. You had a patient, he had AFib 6 months, or in that case it was 12 months. You ablate, PV, region is in sinus rhythm. This was really something that you feel happy. Unfortunately, and this is big stuff, the big problem that we have, I saw yesterday you have seen some persistent AF. There is a lot of confusion, and one of the main reasons of confusion is we have to re-ablate the patient a second time, a third time for the tachycardia. In this review, this is a single ablation, and you see the percentage of success is relatively limited. If you do ablation, you have to say to the patient, you will come back for AFib or for attack, and maybe you will re-come back. And this is what we are facing since years. In a paper, we are, in this paper we publish here, or now, at 5 years, we have only 15%, say 1 out of 7, who had a single ablation. That means for 85% we have to re-ablate. And this was something we believe was normal, and we believe was a price to pay. But you will see then an option. So we had atrial tachycardia. Alors we say atrial tachycardia is better than atrial fibrillation. For the patient it's absolutely the same. But for you feel satisfied about that. And what we observe, and this is the question of the quality of ablation, you have to come back to the same spot to re-ablate some part where you ablate for 10 minutes. So this is really a big problem. The quality of ablation is not transmural enough to have a durable and long-lasting lesion. And then this is something we have not published, but which is being published. This guy and all the young electrophysiologists, they have a look. This is 215 tachycardia patient. They have been ablated of persistent AF. We have terminated their AFib in sinus, but they come back in attack. Most of the attack are macro-reentry. Donc it's a reentry around the mitral isthmus. It's a reentry around the roof, or it's carbotracheospic isthmus. Carbotracheospic isthmus is fine, but this long reentry in the left atrium is big. And we have localized reentry, that means small reentry, and often in some part we have a blade. And then they propose, well, this is a joke with using Napoleon, but success means nothing unless it is lasting, right? But this type of curve is something that is used to symbolize efficacy. Donc probably here we don't do enough, we do PVI and we don't do enough. maybe what we are doing, trying to terminate and ablate all the driver, maybe it's too much. This is a question we are asking. And we try to do durable critical structure, where we do less, but better quality. And this is what happened. Donc, this young electrophysiologist said they are off from Bordeaux. They call it the Martian plan, which is funny because the first part of the Marshall plan, they ablate the vein of Marshall. And you will understand why. So here, there is a big vein that everybody doing CRT or and the vein of Marshall is relatively large arborization on the back of the left vein, and sometimes it's big enough, and you inject some alcohol, like you do for cardiomyopathy, hypertrophic cardiomyopathy, and you get an infarction, a venous infarction. But you had relatively big lesions, epicardial. That means you have performed a chemical ablation of a posterior part of the left atrium. And what happened is easy to do. You use alcohol ethanol, which is absolutely non-expensive. In some countries they use alcohol for cancer treatment or metastasis. It's really a very good chemical ablation. So they start by doing that. In that case, the Marshall was relatively small, and they ablated. Well, you see here, the size of the arborization gives you an idea of what will be the size of the ablation you will create just by injecting alcohol. Then they ablate the top here, the end here. The idea is to eliminate all activity around the mitral isthmus and the left vein. This is the first part. Donc say, first part Marshall here. Second is do PV isolation. Donc very classical. And third one, finish the line, be sure the mitral isthmus is done and the roof is done. Marshall to ablate epicardial part. Everything else is done endocardially, PV and 2 lines. Minimal lesions. But the endpoint is very clear. We know exactly what to do. We don't have the ambiguity that we have when we ablate the cafe, the fractionate, where we don't know when to stop, etc. So high power short duration, ethanol, and this is what happened. This is a patient, he had a low voltage during atrial fibrillation. So you see, if you look at the cafe here, you will say that this is full of abnormal potential, my ablation will be complex. They have done the Marshall here, the roof, and the PV isolation. You look, anterior there is nothing. The roof is on the back here. There is no low voltage after ablation, while during the AFib, it seems that we have a lot of voltage. But what is interesting in that case, your appendage here is activated without any obstacle. Before, when you ablate the rotor, you had a lot of reentry anterior, so we don't have any damage. And when you look at your appendage after ablation, it's there. This is the P wave, appendage is here. If you do some ablation here, you will get appendage sometimes after. And the quality of the contraction looks to be better. But it seems we respect the physiology of the atrium, no ablation in the anterior part of the backman, and better, everything is concentrated on the vein, endo and DP. And this is 10 patient. You see, in this patient we had a relatively small part of the Marshall. In this one the Marshall was bigger, but all the anterior is respected. You have 10 different patients here. And the lesion is always the same, and the Marshall make a difference, small or not. And this is the result we had before, where this is when we had the 5 years report. This is the 6 months or the 12 months report when we terminate AF we had 45% of patients at 6 months, they had a recurrence. When we did not terminate AF, we had 60%. So this is what we have historically. A lot of patients at 6 months have recurrence. And this is what we have. We have, just by doing these completely anatomical lesions, you can do it with a single catheter, without complex catheter, without ethanol. We have a 15% recurrent at 6 months. And this can be, this looks to be a significant progress with something which is very clear in terms of it. The future, yeah, the future is my last slide.
You need 2 minutes?
Yeah.
2 minutes more?
My last slide.
Okay, last slide. Okay.
The future will be,
Yes, it's important.
yeah, minimal actually modeling. Probably we have to do some individual strategy. Some patients without damage will have only PVI. Some patients will have PVI maybe plus 1 drivers. And we are considering that maybe we have to do this type of technique, anatomical, but the high quality in terms of durable lesions that can make a big difference instead of doing this wide ablation. And the second part of the future, there will be new energy coming, electroporation or ultra low temperature. We use both energy in animals in Bordeaux. Looks here at the bottom. This is in a pig of 78 kilograms. This is the appendage. We just deliver one application and there is no more activity in the appendage. So you can imagine if you have a sort of anatomical lesions, very well done, with this new energy, we can dream of some ablation that can be performed in a really quick time. And this is what I think, yeah. There will be, it's a really hard work, and with a new energy and maybe some lesion of durability, I think this will be the progress. And the second point I would like to emphasize, it is not likely that a drug will come in the next 10 years. What we know about the drugs cannot